Neurology quiz number 56. What is fibromuscular dysplasia or FMD? FMD is an uncommon, non-inflammatory, non-atherosclerotic arterial disease of unknown etiology. Epidemiology: 90% of the patients are women. Median age of onset is 52 years. The condition most commonly involves the renal and extracranial, that is, carotid and vertebral arteries. It is equally common at these two sites and co-prevalence is about 65%. However, it can affect any arterial bed. FMD affects the middle and distal portions of the ICA and the vertebral artery at the level of C1 and C2 vertebrae, that is, the distal extracranial artery. These are arterial areas usually spared by atherosclerosis. The majority of cervical FMD cases involve the internal carotid artery, 95%, often bilaterally, 60 to 85%. Vertebral artery involvement is less common and usually coexists with carotid FMD. Intracranial FMD is rare and most often represents extension of extracranial FMD. Rare cases of isolated intracranial FMD with typical angiographic appearance can involve the basilar artery, distal carotid artery, and middle cerebral artery. Pathology: medial FMD is most common, accounting for 80%. Histologically, there are alternating areas of thinned media and thickened fibromuscular ridges containing collagen, resulting in multiple stenoses, alternating with aneurysmal outpouchings. The angiographic string sign is characteristic of this type. The intimal and adventitial types are much less common. Genetics: FMD is more common among first-degree relatives of patients and has been observed in identical twins, suggesting that it can be inherited. Recently, the first gene locus associated with FMD has been identified, a single nucleotide polymorphism in the phosphate and actin regulator 1 gene on chromosome 6. This image shows the pathology: medial fibrodysplasia with dense fibrous connective tissue in the outer layer of the medial layer, disordered inner medial smooth muscle, and collagen deposition. Clinical features: A. Many patients are asymptomatic and the condition is discovered incidentally on cerebral angiography. B. Neurological manifestations. Number 1, headache. The most common manifestation of FMD is headache. Nearly 80% of patients with cerebrocervical FMD complain of headache, most often migraine. The relationship between headache and FMD is poorly understood, and proposed mechanisms include associated uncontrolled hypertension, dysregulation of sympathetic control in the cervical arteries, and heightened dural pain sensitivity. Headache can also be a presenting feature of cervical artery dissection. Another common presenting feature is pulsatile tinnitus, described as a whooshing sound in the ear. It is often associated with the carotid bruit. Number 3, cervical artery dissection. Co-prevalence of FMD and cervical artery dissection varies from 5 to 15% in observational studies. 70% of cervical artery dissection presents with a stroke or TIA in the carotid or vertebral artery territory that may be delayed by days or weeks from the initial dissection. In addition to stroke, cervical artery dissection can also present with focal signs such as Horner syndrome or lower cranial nerve palsies. 4. Intracranial aneurysms. FMD is associated with increased prevalence of intracranial aneurysms. In the US FMD registry, 13% of patients who had intracranial imaging had at least one intracranial aneurysm and 4% had multiple intracranial aneurysms. There is weak data that in FMD patients, risk of aneurysm rupture may be higher at smaller aneurysm size. Diagnosis: this is based on angiographic appearance. Multifocal FMD accounts for 90% of cases and is characterized by a string of beads appearance representing alternating arterial dilation and constriction. Focal FMD is much less common and is characterized by unifocal concentric or tubular smooth narrowing, most often in the middle and distal segments of ICA and V3 and V4 segments of the vertebral artery. This appearance is non-specific and differential diagnosis includes atherosclerosis, arthritis, etc. The third appearance is a carotid web, defined as a thin linear membrane that extends from the posterior aspect of the internal carotid artery bulb into the lumen located just beyond the carotid bifurcation. It is thought to be a rare variant of intimal FMD. However, some authors regard it as a separate entity. Carotid webs are thrombogenic and are implicated in ischemic stroke. CT, MRA, and DSA can all be used for diagnosis. Duplex ultrasonography can be used for diagnosis of carotid FMD, but is less sensitive for evaluating cervical vertebral arteries. This is an MRA of carotid and vertebral FMD showing the typical string of beads appearance. This is an angiogram of the left ICA showing on the same image a large intracranial aneurysm and cervical FMD. Here the image on the left is a sagittal CTA showing a carotid web, and the image on the right is a repeat CTA after a new stroke showing superimposed thrombosis. Treatment: number 1, headache. Migraine management is similar to patients without FMD. Triptans and ergots should be avoided in patients with uncontrolled hypertension, history of stroke, and coexistent coronary artery involvement. 2. Cervical artery dissection. There are no trials evaluating treatment of cervical artery dissection in FMD patients, and treatment is similar to non-FMD cases. This includes use of antiplatelet/anticoagulant therapy. Due to the increased risk of cervical artery dissection in FMD patients, they should be cautioned to avoid activities associated with extreme hyperextension or lateral rotation of the neck, especially chiropractic cervical spinal manipulation. Care should be taken to cushion the neck during surgery, dental procedures, or other prolonged activities with forced hyperextension. Ischemic stroke. The occurrence of ischemic stroke in FMD patients in the absence of cervical artery dissection or other risk factors for stroke is controversial. However, stroke management in these patients should follow standard stroke guidelines. Diagnosis of FMD is not a contraindication to fibrinolytic therapy or mechanical thrombectomy in otherwise eligible cases. Optimal management strategy for carotid webs is not established. For asymptomatic cases, antiplatelet agents are given. For symptomatic cases, medical management includes anticoagulation or dual antiplatelet therapy, followed by monotherapy. However, given the potential for recurrent events, a more invasive approach involving stenting or carotid endarterectomy may be advocated. 4. Asymptomatic FMD. This is discovered incidentally and is regarded as having a good prognosis. It is recommended that such patients should have a one-time vascular imaging of the body, such as CTA or MRA, to screen for FMD in other arterial beds. In patients with FMD and no prior history of stroke, the long-term benefit of antiplatelet agents for primary stroke prevention is unknown.